Well, when you hear such aspiration and commitment, makes me feel very proud to be a North Carolinian. We're going to be in the treat for a great 2 days. We're going to be informal, highly interactive, but I think important, we're going to work together to find the right solutions. And of course, the person who's leading the charge in this state is our Secretary of DHHS, Dr. Mandy Cohen. She's going to give the plenary lecture. We set up in such a way that we have one state perspective, and tomorrow we have Karen DeSalvo to give you the national perspective. So Mandy's been really wonderful to work with, and her staff. I can tell you that she is accessible, committed, and really totally great partner to work with. And so I want to introduce her properly. And again, all of you know her well, but she was appointed to the role of Secretary of North Carolina DHHS in January 2017 by Governor Roy Cooper. Secretary Cohen and her team worked tirelessly to improve health, safety, and well-being of all North Carolinians. DHHS has 17,000 employees and an annual budget of $20 billion, serving as home to North Carolina Medicaid, public health, mental health, state-operated hospitals, facilities, economic services, adult and child services, early childhood education, employment services, and health service regulation. And she and her team are focused on building a strong, efficient Medicaid program, improving early childhood safety and education and health, and combating the opioid crisis. Mandy is an internal medicine physician like me and has experience leading complex health organization. Before coming to North Carolina DHHS, she was the Chief Operating Officer and Chief of Staff at the Centers for Medicaid and Medicare Services, CMS. She brings a deep understanding of health care to state and has been responsible for implementing policies for Medicare, Medicaid, and Children's Health Insurance Program and the federal health insurance marketplace. Secretary Cohen has been recognized as national leader for her work at DHHS. In February 2019, Modern Healthcare named Secretary Cohen as one of the top 25 women leaders in healthcare. As a graduate of Cornell University, she received her MD from Yale, Master's in Public Health from Harvard School of Public Health, and trained at my old stomping ground, the Mass General. And I must add that, as I said, it's wonderful to work with her and her office, especially Betsy Tilson. And North Carolina is really lucky to have leader, that Mandy Cohen as our leader. So please help me welcome Mandy.
Good morning. So, it's been a week. But so thank you for the kind words, because I kind of needed it this week. But this is such, I think, a well-timed conversation that we're going to have over the next 2 days here. I'm so grateful to Dr. Zhao and the National Academy for choosing North Carolina as the first site to think about taking the Vital Directions blueprint on the road. I think it's the right choice, not just because you're a North Carolinian, because I think there's incredible work going on here. And while we did have a setback, and for those of you who haven't read the news, because of some gridlock, we aren't going to be able to move forward quite yet with our managed care implementation, which has a lot of the pieces that we'll hear about built into it. But despite that setback, it's given me this opportunity to sort of reflect on the last 3 years that I've been here in North Carolina and what we've been working on and accomplishing. And it was an opportunity to remember that it was always bigger than just this transition to managed care. And so I'm going to talk through a lot of that. And someone asked me, oh, did you have to spend a lot of time rewriting your speech? No. Because I wanted to talk about our blueprint here in North Carolina, because I hope it is helpful for us as North Carolinians to remind ourselves where we're headed, but I hopeful for those of you not from North Carolina are here to learn with us that maybe that is also a blueprint that you can use as you move forward. And I've been talking specifically about how we focus on health and not just health care for a number of years. The term social determinants was a buzzword for a long time. And what I'm really proud about in North Carolina is we've taken that buzzword and turned it into a reality, and trying to make all the pieces related to health actually real here in North Carolina. So I'm going to talk about that blueprint. And this was, I see some headlines written about North Carolina, we're the most innovative state, and I'm so proud when I see those things. But what I think is innovative about what we are trying to do is really that we have looked very hard around the country for what are the really great things that are going on around the country, and how do we bring them here, and how do we take them to scale in a thoughtful way. And I think that's what's exciting. So it's not that value-based care started here in North Carolina, no one thought of that before, right? It's a matter of like, okay, that seems to be working. Let's look at the evidence and how do you scale that? It's not that we didn't realize that food was important to someone's overall health. It was a matter of like, how do we actually operationalize that at scale for folks and move folks forward? So what I think our innovation is, and this is a collective innovation, is our commitment to health. And so I want to walk through what that blueprint is. And I will say, as most recently as when I was at the federal level and I was the chief operating officer, chief of staff at the Centers for Medicare and Medicaid Services, I was thinking about health care. And so I don't want to say that the folks who are thinking about health are doing anything malicious. I just think that was the mindset and the way that I had been thinking about things for a really long time. And it wasn't until I came to North Carolina and saw all these different levers coming together that we were able to do something different. I was a product of learning directly from Don Berwick and the Triple Aim and IHI, and thinking about reduced costs and better care and better health. And we talked about it all the time, right? Triple Aim, now it's even the Quadruple Aim. But even all of the years I spent at CMS, and if you think about your work right now in the healthcare system, those of you who run big provider organizations in particular, those of us who are payers, we spent most of our time thinking about two parts of the triangle. Right, when the reduced cost part, right, as payers, we think about utilization management and formularies. On the better care side, we were thinking about hospital-acquired infections and making great improvements there, but we didn't really embrace talking about the better health pieces. What I'm excited about in North Carolina is us all collectively driving towards that other point of the triangle, and I think there are two particular trends that are helping us get there that I'm going to talk about. Some incentive pieces that we've thought about changing, and then some infrastructure pieces that we've thought about changing. And so these are my shorthands for value-based purchasing, or moving to value contracting, and social determinants, which is the last time you'll hear me say that, but our healthy opportunities work in the infrastructure we're building there. And I think that is what's going to move us from just focusing on two parts of the triangle to actually focusing on all of them. And so here is my little blueprint for what I think we're trying to achieve in North Carolina. And as I reflect over the 3 years that I have been here, this is where I think that we have come. And so it started with a commitment to a clear vision of health, and I'll come back and talk about that. Then it's this aggressive alignment around incentives and initiatives that lead to important action, right? I will say some of the incentives built into healthcare right now actually prevent you from focusing on health. It's actively keeping you from doing the thing that would help you focus on health. And then there's been this incredible alignment of cross-sector investments. And that has been just game changer here. And there are many of you in the room have been part of that cross-sector investment. And it's just been something that has accelerated the work. So we committed to a vision, we aligned incentives, and then aligned that infrastructure investment. So let me go through that a bit and just take you on a trip down memory lane. When I joined here in North Carolina, the very first meeting that I went to, the big annual meeting of the Hospital Association, before they've changed their name as well, their session was focused on the social determinants, or on the non-medical drivers of health. They had a bunch of different speakers, and there was all this energy and thought of like, oh, this is interesting, how do we do that? The Medical Society, under Bob Seligman's leadership, had already invested in a lot of different ways through the Physicians Foundation and others, and thinking about how can we move towards health. We were faced with a huge opioid crisis, as mentioned by the governor, and how do we put those pieces together. I was new to North Carolina. I did a lot of listening and talking to folks, both sides of the aisle, asking folks, well, what are you worried about in the healthcare space? And they rightly pointed me towards, I'm worried about some things in health, whether it was rural health and access to care, or I'm worried about that folks are dying young when they shouldn't be, or infant mortality rate and the disparity. And I saw this opportunity here in North Carolina that was already happening, and I don't think that it was anything I particularly did, but I saw the folks all running in a direction, and what we needed to do was take that energy and direction and turn it into an agenda that allowed us to actually do the things that I think it would take to transform the state and drive us towards health. And I also knew we were in a challenging political environment, and I was right, this couldn't be about something new, meaning like that I was going to create, we were going to create this big plan, and we were going to go to the legislature, and I'd go to my boss, the governor, and say like, hey, we should invest X number of new dollars in something. I knew this was going to have to be about using the resources we had wisely and efficiently. And so as part of that, we came up with this vision for overall how we were going to think about moving to health. We interviewed many of you who are sitting in this room about how we can do that. And it started with my own department, right? So I'm just not the head of Medicaid, right? We're not just a Medicaid agency. We have so many facets to what we do at the department that focus on health, whether that's obviously integrating the physical and the behavioral health sides, we have mental health, so many of the critical public health pieces, whether that's just about clean water or about making sure our restaurants are safe, but also about the big public health initiatives and so mental health, public health, and all of the human services side, so all the economic benefits, child welfare, adult protective services, economic services. How do we think about, even as a department, before I even got you all, how do we as a department do our jobs differently? And that meant we had to actually be different as a team. We had to make decisions more collaboratively. We had to work on teams together differently. And then how do we bring in everyone else to that shared and collective work? And this was the vision we came up with. We envision a North Carolina that optimizes health and well-being for all people by effectively stewarding our resources that bridge our communities and our healthcare system. I think we needed to acknowledge, and I'll say this first as a doctor, that all the problems are not going to be solved by the healthcare system, right? This is a partnership that we're needing here, and everyone needs to be rowing in the same direction, whether it's our early childhood teachers or our community colleges who are going to train our community health workers, or the CEOs of hospitals and payers. So this was our vision. And then we took that vision and plotted it out against some really hard tasks that we need to do. You heard from the governor about the opioid action plan that we put together, really, again, cross-functional, multidisciplinary type of work to say that it's not going to just be treatment alone, right? If we just said, we're going to put all our resources into MAT, yay, that's not going to solve the opioid crisis. We needed this comprehensive way of approaching it. Same on early childhood action plan, where we have 10 goals, very comprehensive across health, safety, and learning. We've been incredibly lucky as a state from the time that Governor Hunt was the governor here in investing in early childhood education, national leader in it. I knew about it before I came to North Carolina. But education without thinking about the health and the safety, right? Then you have kids showing up hungry at school. You can't learn when you're hungry, right? And so linking all those pieces together in a comprehensive look at early childhood. And then, of course, our Medicaid transformation, right? This was where we as a payer and a market mover could think about not just changing Medicaid, but use that as a catalyst to move forward. And we were lucky that we had a partner in the other big payer in the state who wanted to move quickly in that same direction, and frankly, well faster than Medicaid. If anything, I just wanted to align with where they were headed. And so as we thought about what we were going to do in our Medicaid transformation work is really about improving the health of North Carolinians, and you'll see it doesn't say Medicaid beneficiaries. It really was about moving the market through an innovative, whole-person-centered, well-coordinated system of care that addresses both the medical and non-medical drivers. So you can see how that big vision of health, where we were optimizing resources across the department, really started to infuse our work at the department, infuse our work in Medicaid transformation as well. So that's the first step, right? Because you got to know where you're going in order to align all of these other factors around there. And so it was a fair amount of work right at the beginning to know where we were headed and how we would all get there. And so then let's move to the incentive pieces, right? Because I think these are so critical, right? As we think about moving towards health. If you're going to have a system that pays for pieces and rewards volume, you're just not going to get to health. And it's not because anyone's malicious, right? It's not that the CFOs at some hospital are bad people. They are responding to the system we have created, which is fill your hospital beds. And so if we want to get something else out of the system, and if we want to get health out of our system, we want to buy that with our resources, we have to do something different. That's why I think the incentives are so important. And this started at the national level in the work that I was lucky enough to be part of at the national level, where Medicare was the leader here in saying we're going to pay differently. And you can see both Medicare Advantage, traditional Medicare, you see are the leaders here with more than half in Medicare Advantage and nearly 40% in traditional Medicare. By the end of 2018, we're in these alternative payment models. And some would say, oh, was that an Obama thing? Is that an Affordable Care Act thing? But what we're seeing is Secretary Azar and the new administration embracing those changes and frankly accelerating those further, which is fantastic. And I think you'll hear more about that over the next 2 days about the work going on nationally. And what I see as really exciting in North Carolina is that really taking hold here, because I do think that's important that we get the incentives right. In North Carolina, we have 30 Medicare and 6 commercial-only ACOs operating the state. You'll hear more about the Blue Premier program and other participations in accountable care organizations, right? Because someone needs to really think about health holistically as we're moving forward, and the incentives is a huge piece of that. So here was our blueprint from the Medicaid side, as I heard, how do we contribute to the incentives and the initiative piece as we think about moving towards health? And many of you in the room have been part of creating this. And yes, while we have a temporary setback in when we move to managed care, I think you are going to continue to see us make progress along these domains, even as we see where we go in terms of timing of implementation of managed care. So the first was a recognition that physical and behavioral health has to be integrated. Again, not a new concept, not innovative to North Carolina, but just learning great lessons from around the country to say we have to think holistically about folks' care, not just for those who have serious mental illness, but those who in our Medicaid population who are our moms who may just have postpartum depression still need to be thinking about the holistically. Second, we wanted to make a huge investment in primary care, recognizing that the data shows us investments in primary care and particularly hyper-local care management and a huge investment in that navigation and care embedded at the practice level was really important. So we did that through an advanced medical home program that we hope to launch in managed care. But again, this was something Medicaid had already invested in, right? The CCNC program for many years has already invested in this direction of knowing primary care and local care management. If anything, I just wanted to accelerate that and double it, frankly. And then the value-based payment, right? This was, again, us aligning with what we were seeing at the national level, what we were seeing in Medicare, commercial space. And so thinking by the end of year 2 that we would have some alignment as we move to managed care. Again, this wasn't going to be something that was going to happen on February 1st, right? This was a long-term play because changing those incentives are hard. And getting to that right mix, particularly in the Medicaid space, is newer for folks. And then wanted to have that unified quality strategy and that not only stopped thinking about all those processing measures and really focused on health measures, but also thought about total cost of care. So again, that was sort of the playbook embedded into our tool of moving to managed care. But now with where we are in timing of implementation, you will see us think about how can we continue to move forward along these lines to continue that change in incentives so that we move towards health. All right, so we had our vision. We were starting to change some incentives to get folks moving in the right direction. But then we had to actually invest in some infrastructure. You cannot push risk down from payers to providers. You cannot just say, I'm just going to tweak the rules of the road a little bit and hope everyone figures it out. This is a different way of operating our healthcare system. To think about health, and that means you have to invest in some things. And there's more investment than just these things, but I want to talk about the 3 that I think are game changers and how we do that. And so this also are investments that are not exclusive to Medicaid. These are investments for North Carolina, and you'll hear more about them. And they're all related to buying health or related to the social determinants or our portfolio of healthy opportunities. So first was around standardized screening, and you all have heard my story many times of my patient where I did everything wrong, and I did not ask my patient a very basic question about her health. I didn't ask her if she was running out of food. And for 8 weeks of my knowing her, I ordered expensive lab tests, I CAT scanned her belly, but I didn't ask her about food, and I didn't actually help her one bit. I didn't make her one bit healthier, and I spent thousands and thousands of healthcare resources. So that burns on my mind when I think about how do we create a system that recognizes all of these facets of health, right? Because it's not bad people, right? I went to some pretty fancy, very expensive schools, and I'm a nice person, so it's not like I was being malicious. We didn't have a system that was set up to ask questions in a standardized way and then navigate folks to resources that could help folks with their health no matter what door they walked in. Now, if they walked in a door of a community health center in Boston, they would have been asking these questions. They would have been navigating them to resources, right? So this is not North Carolina. We woke up in North Carolina. Folks have been doing this. Now it's a matter of how do we take it to scale? Right? How do we do it everywhere? So we wanted to have a standardized screening tool here in North Carolina because you got to have, we're North Carolinians, got to have our thing. And so what we said, what works for us? Right? I was obsessed with getting it under 10 questions, but we came up with a tool that was 9. Yay, well done. This advisory committee. And now, yes, we were going to have, as we move to managed care, we were going to require all of our managed care companies to screen 1.6 million beneficiaries starting next year with this tool. But we're not exclusive to managed care. I hope this tool is used by all different practice settings, and it frankly doesn't need to be healthcare settings, right? So I think this tool will hopefully be used in a lot of different places. I know that some of our Medicare Advantage plans are using this. I know a number of our practices are. I will say, so my own pediatric practice is using this tool. Raleigh Pediatrics, go you. Right, so when we check in for our appointments, we go through this tool. Now, it doesn't solve all our problems, but if we're not asking this in a routine way, we're not actually going to be surfacing all of the issues related to some of our patients' health and actually help them get the resources they need at the time they need it. So we're excited about that. And I hope, despite the fact that we don't have a managed care requirement starting in February, that we're going to see more adoption of this tool. But the second thing is if you're going to ask the question, hey, are you running out of food at the end of the month? Well, you better be able to help someone when they say, I need help. And that's a scary thing, I'll say, as a doctor in a doctor's office, right? Because I went to medical school because I want to help folks, right? And the idea of opening up, right, that can of worms of, oh gosh, food. Okay, now I have to solve poverty in addition to all the medical stuff. Yikes. But it doesn't have to be so overwhelming. And so what we said is, okay, if we're going to need to ask these questions in a standardized and routine way, we have to have an easy way to help folks navigate. And this is where the beauty of NC Care 360 comes in. How many folks have heard of NC Care 360? Yes, I love you. I was at a talk yesterday, which I love, with my folks in the nursing home community, and I asked them to raise their hand if they heard of NC Care 360, and only one person did. So we have our work to cut out, so thank you, Coalition of the Willing, on this. So you know what NC Care 360, right? It's embedding in electronic health records, and really this is the epitome of that, of embodiment of that vision, the knitting together, the optimizing of the healthcare and human services, the knitting together of our healthcare system and our communities. And as a doctor, I'm obligated to say I hate technology, but we're really trying to find a tool that's beyond technology here. And what's been exciting about this platform and the way that our partners have gone about it, thank you to the Foundation for Healthcare Leadership. You're going to hear more from them and our partners at United Way and Expound 211 and Unite Us. What's great about how they've approached the work is the IT is secondary. It's the relationships that are primary. And here I see Kathy, who is just such a champion for this, from Cohen, and was the first one who said, yes, let's figure this out. What is it really about? Building relationships. And right, if we're going to make progress at knitting together health and human services, it's got to start with relationships. And if anything this week has taught me is that change only happens at the pace of trust. And I'm learning that lesson more deeply every day. And that's whether that's in the trust in our political system or trust that we can all work together and invest collectively. But this is a place where I'm really excited to see what this is. So we are deployed already in nearly half the counties in North Carolina and on track to be in all 100 counties by the end of 2020. And I want to thank, there's a number of folks who have funded and supported this work. It is almost exclusively supported by all philanthropy. And we did that intentionally to have it live outside of DHHS, to be this collective platform that the state can use. This is not for Medicaid. This is for the state. So actually what we're seeing is a lot of folks, particularly in our aging population, use this platform. So I'm really excited about this. We're getting some good data back already. We've had over 1,500 referrals through the platform, and we're already learning from that data about how we can continue to optimize what's going on in our communities and what's going on in healthcare to really drive towards health. So I think this is the game changer. So keep your eye on this and this work. And if you're not already having your organization engage in it, make sure you're talking with us. And I want to thank Betsy Tilson and Erica Ferguson, who have just been unbelievable champions in doing this work and working 24 hours a day, 7 days a week, getting it this far. I had sort of this figment of an idea in my head when I came here, and they are the ones that made it reality with these partners. So they're fantastic. All right, that's another piece of infrastructure. And then the pilots in Medicaid is the other part of the investment, and this is another investment from the state, where I want to help all of us learn about, well, what healthcare dollars should we use to pay for things that might not be traditionally healthcare? And that's a very slippery slope, and folks get very nervous about it. And I will tell you, when I've sat at the federal level, we were nervous about it then. And so the fact that in a bipartisan way, we negotiated with the Trump administration to say, hey, can we get some flexibility to really learn here and figure this out? I thought that was an incredible opportunity to, again, bridging both sides of the aisle, bridging health and human services to say, okay, let us learn about how we're going to spend dollars a little bit differently if we actually want to buy health. If we want to buy health and really embrace that, we can't just keep buying the same stuff. We got to buy other stuff. Like, the classic example of the kids with asthma, and I've change my example a little bit, but because I can't buy them new carpet because apparently carpet's bad overall for asthma. But instead, we're going to rip up their carpet and give them linoleum. So it doesn't sound quite as nice, but we're going to give them hardwood floors, right? Because those are the kinds of things, like we should use our Medicaid dollars to buy that, because why am I buying emergency room visits when what I want to buy is health? So this is the opportunity to learn. And we are going to continue to move forward with this work. The cadence of this pilot was actually not meant to launch until 2021 in terms of service delivery. We're doing a procurement now for the lead pilot entities, and then there was a fair amount of time of capacity building and building things up. So we're going to continue marching forward with this work, and so I'm encourage all folks who are interested in this to stay engaged in this, because it was running at a delayed cadence from the start of managed care. So I think we have a bunch of run room to still get ready for this pilot. Again, I think managed care is a when, not an if, and so we're continuing to run forward with this work. But this is going to be huge, and not just for Medicaid, but so I can tell my fellow other payers to say, this is what you should invest in, because we realized when we were writing the rules around managed care, I wanted to tell the insurance companies to say, you must spend your money on this food intervention. And then we looked around at the literature and realized we didn't know exactly what to tell them to buy or to do or to invest in. And particularly, we didn't know what set of patients and what phenotype of patient or family needed a particular kind of intervention. So this is going to be the exciting thing, and it is the work that we did on this started with thinking about evaluation. My first call was to UNC and to Seth Berkowitz to say, help me design this so that we can actually evaluate in a way that we can learn. So I'm very excited that this work continues. Again, all of these under ongoing investments. So let me end with some challenges. Well, I have one more slide. Don't worry, I'm still the half glass full kind of gal, so I can't end on challenges. But so let me talk about some how I see things moving forward. So yes, we have political uncertainty, and that's not just about managed care implementation. We're going to do a lot of happy talk the next 2 days about how great North Carolina is, but honestly, the black eye of North Carolina is we have not expanded Medicaid. It's embarrassing. It's embarrassing, and it's well overdue, but it is also so necessary to help all of these things that we want to accomplish here be successful. I know this is the coalition of the willing, and all I would ask is that you continue to have conversations in different ways to help folks understand what's going on here, and hopefully to get out of the partisan corners and to get to moving forward here. So political uncertainty is always challenging, but we will work through this. And like I said, I think this is a matter of when, not if, and right, it is right to make sure that we can have all tools at our disposal to make us a healthier state of in North Carolina. I was asked yesterday by a reporter, about all of the things that we're doing in managed care, and aren't you so sad, and you're getting national attention, but honestly, the thing that we could do that would move North Carolina forward the most in terms of fighting the opioid crisis and reducing infant mortality and helping our rural hospitals, it's not managed care. It's Medicaid expansion. And so I just want to make sure we get our priorities right on that. Now, I am fully committed to moving to managed care. I think it's important because we built in all of these pieces, but we got to keep our eye on the ball here. Okay. Then let's talk about all the change, right? If we're going to change from asking our system, I want health care, to I want health, that's a big change, right? That means many folks are going to be waking up every day doing different things in our healthcare system. And that kind of change management, and I'll say we're doing that at the department, right? We are thinking differently. We are operating differently. We're making decisions differently. We're budgeting differently. We're thinking programmatically differently. That change management is hard. It takes a constant recommitment to the big aim that you're aiming for, and it takes really thoughtful leadership over many, many years, which is really hard, particularly if you think about government, when things change often in the government space, and even in any organization, you have changes in leadership. So continuing to focus on why we're doing all of this and focus on that change management is really important. You're going to hear about data infrastructure modernization. I think that the reason I think this can be successful now than maybe back in the 90s when similar activities were tried is because I think our data infrastructure is already so much better, but it needs to get way better and easier for folks to use as we move forward. So there's a whole session on this, and I'll let them get into it. But at the end of the day, I'll go back to the change happens at the pace of trust. And that's about culture, and are we going to all link together here and say, yep, we're still committed. Yeah, we had a setback. Yeah, we all have different ways of viewing the world, but are we still aiming towards health and doing that together and sustaining that kind of culture change? So I'm going to end on thinking about achieving better health as a choice. I think we've made a commitment over a number of years to a vision of health. We've been aligning incentives and initiatives. We've been aligning that infrastructure investment, and we've continued to make that choice. And I know that we will continue to make that choice going forward. And so I just am so appreciative that folks have committed to this vision, that we've had this shared commitment to this vision of buying health in North Carolina. And it's not just the department, and it's not just our dominant payer of Blue Cross, right? It's really been a collaborative effort to this vision of buying health, to this partnership and alignment. And really, it's all about the children, the families, the communities that we serve, right? That is hopefully what you will remember from today, is that I think North Carolina is special. It is. It's not because we have necessarily the best institutions, which we do, and not because we have the best doctors, because we do, and not because we have fantastic we do, but it's because of that shared commitment. That is why I think we are getting the attention and we're able to accelerate progress faster here. So I am very hopeful for the future. I know we're headed in the right direction. I think these 2 days of learning are going to recommit us to that path, and hopefully we'll accelerate our progress even further. So I'm just honored to be in this role, grateful to have this opportunity to work with all of you as we trot some very hard ground. Like, this is really hard, but it's right. It's the right direction, and I look forward to continuing to working on it with you. All right. Thank you.
So thank you very much, Secretary Cohen. I think this illustrates, real leadership, and we're so pleased that she is, in fact, our leader. She said North Carolina is special, and I totally agree with it, which is what I said myself as a Carolinian. We live here, we work here, even though I'm in Washington, and we solely believe in this. A couple of points I thought she made. I just want to reemphasize this. First, Medicaid expansion. I think the data is very clear that Medicaid expansion through the 30-some states that adopted it, that's making a huge difference. And, I think that, Mandy, keep going at it. Governor, I think we need it. Second is that what she's doing in bringing the social dimensions to healthcare is critically important. I want to call your attention to the book here that you all have. In fact, on page 1465, the book's not that big, but it's an article in here that I wrote with my steering committee. There's a figure in here which is figure 4 from Elizabeth Bradley's work. And what that figure says is that if you look at the cost of health care, we are by far the largest in the world. But if you look at cost of health care and social expenditure rate to health, we're actually middle of the pack. That simply means we're putting so little into social expenditures. And what you're doing, Mandy, is the exact right thing, because by investing in the social aspects of health, we're going to need much less health expenditures. So I think that, thank you for your leadership.